Muy buenas noches, tengan todos. Bienvenidos a la sesión mensual de este mes de mayo. En esta ocasión tendremos el tema de anemia aplástica y la sesión está muy interesante. Como siempre en las sesiones mensuales tendremos un caso clínico que será presentado en esta ocasión, le corresponde al Hospital General. Entonces, el doctor Santiago Jiménez, que es residente de hematología de esta sede, presentará el caso clínico y posteriormente tendremos las presentaciones de dos expertos. Una es la doctora Amy Discern y el otro es el doctor Phillip Scheinberg, que conocemos muy bien, y ellos tendrán un debate sobre el tratamiento en un paciente joven con anemia plástica. Ya lo dirá la doctora de Michelis, no quiero adelantar más, pero posteriormente también tendremos una presentación sobre anemia de Fanconi para que los compañeros hematólogos pediatras también tengan esta conversación con el doctor Fiesco. De tal forma que la sesión es muy atractiva, espero que así les parezca a ustedes y sean bienvenidos y en un momento más nos dará la bienvenida y el programa la doctora Roberta de Michelis. Gracias.
Gracias, doctor Mellón. Gracias a todos por estar aquí en esta sesión mensual sobre anemia aplásica. Les damos, pues, como cada sesión, la bienvenida a todo el comité de la mesa directiva 2021-2023. Y también, antes de hablar ya más específicamente de la sesión, queremos, pues muchos de ustedes ya se han ido enterando a través de las redes sociales de AMEH, pero para los que no, tendremos nuestro congreso anual en estas fechas, entre el 26 y 29 de octubre, en la Expo Guadalajara. Va a ser un congreso 100% presencial, entonces vayan todos reservando sus fechas porque vamos a tener pues un programa académico muy atractivo y muchas actividades muy interesantes. Para empezar, les voy a presentar a nuestros ponentes con el programa académico. Como ya mencionaba el doctor Mellón, este mes le corresponde al Hospital General de México. Nos va a presentar un caso clínico el doctor Gerardo Santiago Jiménez, que es residente de hematología del Hospital General de México. Lo acompañan aquí tanto el doctor Carlos Martínez Murillo, que todos ustedes lo conocen muy bien, que es el actual profesor titular del curso de hematología del Hospital General de México, y también el doctor Efren Montaño, que es quien lleva la clínica de falla medular en dicho hospital, y ellos estarán con nosotros en una mesa redonda al final de las otras dos presentaciones de nuestros ponentes para poder discutir. La sesión del día de hoy tendrá un formato un poco distinto. Empezamos con el caso clínico como siempre, pero después vamos a tener un debate. Les voy a mostrar como última diapositiva un escenario clínico sobre el cual vamos a debatir. Y nuestro primer ponente para debatir va a ser el doctor Phillip Scheinberg, que todos ustedes seguramente lo conocen muy bien. Él es hematólogo oncólogo, formado inicialmente y estuvo algún tiempo en Bethesda, en Estados Unidos. Es actualmente el jefe de la clínica de hematología en este hospital en Sao Paulo, Brasil. Es doctor en ciencias también, ha sido investigador en muchos ensayos clínicos enfocados a la inmunosupresión en anemia aplásica. Es, de hecho, pues autor de muchas de las publicaciones más relevantes en este tema. Y, de hecho, el doctor Scheinberg va a tratar de debatir pues, a favor de la inmunosupresión en este escenario clínico que les voy a presentar. Nuestra segunda ponente es la doctora Amy Discern, que ella es pues, hematóloga oncóloga en el Johns Hopkins, en el Hospital Johns Hopkins. Es directora del programa de falla medular y síndromes mielodisplásicos en el Centro de Cáncer de ese hospital, profesora de oncología y medicina en ese hospital, investigadora principal en diversos ensayos clínicos, igualmente autora de múltiples publicaciones, y su área está un poco más enfocada al trasplante, y es por eso que ella va a debatir a favor del trasplante en este escenario clínico. Y después de la mesa de discusión que tendremos después de estas dos ponencias, tendremos al doctor Moisés Fiesco, que él es un genetista del Instituto Nacional de Pediatría, con maestría y estudiante de doctorado, que tiene una línea de investigación muy interesante y mucha experiencia justamente en anemia de Fanconi. Entonces tendremos esa plática al final con él para ver el panorama actual de la anemia de Fanconi en México. Antes de pasar a algunos anuncios, les voy a presentar este escenario que es sobre el cual debatiremos, uno de nuestros ponentes a favor de inmunosupresión y el otro a favor de trasplante, que es este escenario. Una mujer de 22 años que empieza pues con sangrados, fatiga, palidez, sin ningún antecedente relevante. Esos son sus laboratorios, con neutropenia con 230 neutrófilos, hemoglobina en 8, plaquetas en 18,000, con una biopsia de médula ósea hipocelular, sin alteraciones en cariotipo, sin clonas de hemoglobinuria paroxística nocturna y se diagnostica una anemia aplásica grave. No tiene un donador compatible para trasplante y pues debatiremos en un escenario similar a este sobre cuál es el mejor tratamiento. Y antes de pasar a la presentación del caso clínico, algunos anuncios que siempre son relevantes. Acuérdense, por favor, de descargar la constancia de la sesión antes de desconectarse el día de hoy durante la misma sesión. También en la misma plataforma pueden elegir el idioma en el que quieran escuchar las charlas de nuestros ponentes del debate, que su charla en original será en inglés, pero pueden escuchar la traducción simultánea eligiendo el idioma de su preferencia. Y también recordarles que en la misma plataforma pueden hacer preguntas, las pueden ir haciendo en el momento que quieran, yo las voy a ir recibiendo para poderlas hacer a todos nuestros panelistas en el momento de la mesa redonda. Y también si tienen algún problema técnico, hay otro icono en la plataforma donde pueden pedir soporte técnico. Y finalmente, pues antes de pasar a la presentación con nuestros ponentes, agradecer a Novartis por el apoyo para la realización de esta sesión. Entonces, sin más, yo me despido con esta diapositiva y empezamos con la presentación del caso clínico. Bienvenidos a todos.
Buenas tardes. En esta ocasión correspondiente a la sesión mensual de la Agrupación Mexicana para el Estudio de la Hematología, corresponde el caso clínico de anemia aplásica. Entonces, comenzamos. Como ficha de identificación, tenemos a un paciente masculino de 33 años de edad, originario y residente de Cuernavaca, Morelos, con escolaridad, bachillerato incompleto, estado civil, unión libre, religión católica y actualmente no cuenta con un empleo. Dentro de los antecedentes personales no patológicos, cabe mencionar que el paciente habita en casa rentada y que no cuenta como tal con todos los servicios de urbanización. Sin embargo, el paciente no cuenta con exposición a citotóxicos. Los alérgicos fueron interrogados y también son negados. Dentro de los antecedentes personales patológicos, el paciente no cuenta con crónico-degenerativos y aparentemente quirúrgicos fueron negados. Entonces, dentro del padecimiento actual, tenemos a un paciente que inicia en diciembre del 2019 con astenia y adinamia progresiva. Posteriormente, el paciente acude a medio particular donde se documenta pancitopenia por estudios externos y es referido a nuestra unidad. Inicialmente, el paciente se mantuvo afebril, sin evidencia de organomegalias, y únicamente se documenta una gingivorragia leve, el cual fue limitada. Entonces, dentro de los escenarios clínicos tenemos diagnósticos sindromáticos, dentro de los cuales podemos caracterizar un síndrome anémico, en el cual fue caracterizado por astenia, adinamia y la palidez generalizada. También se consta de un síndrome purpúrico caracterizado por púrpura húmeda, en el cual se evidencia la gingivorragia leve limitada y petequias en extremidades inferiores, esto tomando en cuenta los paraclínicos que en un momento vamos a comentar. Sin embargo, el paciente se buscó de forma interrogada sobre síndrome febril, pese a la neutropenia que presentaba, el cual fue descartado, y un síndrome consuntivo, en el cual también fue descartado. Dentro de la exploración física, cabe mencionar que el paciente estaba reactivo, con palidez subconjuntival y gingivorragia leve a la exploración de la cavidad oral. Dentro de lo cardiovascular, tórax y abdomen no se evidenció alguna alteración. y en lo hematológico únicamente con presencia de petequias en espalda y extremidades inferiores, sin evidencia de hepato ni esplenomegalia, ni adenopatías. Dentro de los laboratorios para clínicos iniciales, tenemos que nuestro paciente cuenta con la siguiente citometría hemática, en el cual se denota un descenso de la hemoglobina hasta 6.5 gramos sobre el decilitro, con los índices normocítico y normocrómico, en los cuales cabe mencionar también una baja en el conteo de los leucocitos con neutrófilos de 100 y plaquetas en 4000, con reticulocitos de 0.6%. También cuenta con otros paraclínicos como química sanguínea, en el cual se encuentra dentro de parámetros sin evidencia de afectación hepática y con un examen general de orina sin alteraciones. Conforme a esto, se realizó el protocolo y en este paciente con pancitopenia, se realizó frotis de sangre periférica en el cual no mostró células anormales ni fragmentación de glóbulos rojos y por tanto las plaquetas se consideraron dentro de tamaño normal. El aspirado de médula ósea es marcadamente hipocelular y no se observaron células anormales. La biopsia de médula ósea, realizada de forma inicial el 1 de febrero de 2020, fue una médula ósea hipocelular menos del 10%, con disminución de la maduración de las 3 líneas celulares hematopoyéticas compatible con aplasia medular. Importante mencionar que existe la presencia de tejido graso que sustituye al tejido hematopoyético. Con base en los hallazgos mencionados anteriormente, se sospechó de anemia aplástica y, conforme a los paraclínicos de extensión, se mantuvieron o se estuvieron excluyendo algunas otras patologías. Se realizó test de Coombs, en el cual se descartó síndrome de Fisher-Evans y además se realizaron otros paraclínicos como niveles de vitamina B12, ácido fólico, así como un perfil inmunológico, el cual resultó negativo. Cabe mencionar que a este paciente también se le realizó de forma indirecta un cuestionario para descartar antecedentes infecciosos, en el cual fue corroborado con un panel viral, el cual resultó negativo. Incluso tomando en cuenta que en el frotis de sangre periférica no mostraba alteraciones o fragmentación o presencia de esquistocitos, aunado a que no presentaba afectación neurológica ni renal, se excluyó el diagnóstico de púrpura trombocitopénica trombótica. Se realizó además un cariotipo en el cual fue sin alteraciones y un perfil molecular con la detección de afectación de metiltransferasas y ASXL1, el cual resultaron negativos. Cabe mencionar también de forma importante que los estudios de inmunofenotipo no mostraron evidencia de leucemia, mielodisplasia o hemoglobinuria paroxística nocturna ante la presencia de clonas, y bien se descartó un síndrome mielodisplásico hipoplásico. Y también, para descartar cualquier malignidad subyacente, al paciente se le realizó una radiografía de tórax y una PAN-TAC, una tomografía de 5 regiones, en el cual no se evidenció ninguna anormalidad. Finalmente, el paciente fue diagnosticado con anemia aplásica muy grave, adquirida e idiopática. Entonces, con base a, para la realización de tratamiento, en este paciente cuenta con un hermano HLA compatible. Sin embargo, por cuestiones de pandemia, no fue posible llevar a cabo el protocolo de trasplante a médula ósea y se optó hacia la inmunosupresión y el uso de trombomiméticos. Y así, el 11 de mayo del 2020, se inicia tratamiento con ciclosporina a dosis de 700 miligramos vía oral, dividido en 2 tomas, y además se agregó el trombopac 150 miligramos cada 24 horas. Y es importante también mencionar que inicialmente el paciente se mantuvo con soporte transfusional eritrocitario y plaquetario. Se evitaron miembros de familia como posible donante en cualquier transfusión de hemoderivados. Por tanto, tenemos también la subsecuencia de algunos paraclínicos o de los paraclínicos que se fueron tomando al paciente, en el cual tenemos la citometría hemática, en el cual hubo alguna pequeña mejoría desde el punto de vista de los parámetros con la hemoglobina, y la cifra de plaquetas. Por tanto, también se agregan otros paraclínicos como química sanguínea, pruebas de funcionamiento hepático, electrolitos séricos, el cual no mostraron alteraciones. Así como lo complementario con niveles de hierro sérico, un perfil tiroideo, el cual resultó dentro de la normalidad, y un nivel de hepcidina, el cual se mantuvo dentro de rangos de referencia. Posteriormente, el 19 de mayo del 2020, se realizan niveles séricos de ciclosporina, de los cuales se mantuvo en 263 nanogramos sobre mililitro, el cual se mantiene en dosis sérica recomendada. Por tanto, nuestro paciente continuó con la misma dosis de 700 miligramos por día, dividido en 2 dosis. Cabe mencionar que también al paciente se realizaron cuestionarios dentro de la escala FAC para valorar la fatiga, que se pudiera documentar ante el tratamiento. Y por tanto, el paciente mostró un puntaje con mejoría evidente. De forma relevante, a 2 meses de tratamiento, el paciente se mantuvo ya sin requerimiento transfusional. Posteriormente, el paciente presentó toxicidad por ciclosporina A, caracterizado por parestesias, cambio en el estado de ánimo, náuseas y vómito. Se le realizó niveles séricos de ciclosporina, el cual resultaron en 487 nanogramos sobre mililitro, un poco más incrementado de los niveles séricos recomendados. Por tanto, se disminuyó a la dosis acorde a los niveles séricos 100 miligramos de la dosis total y se mantuvo con ciclosporina 600 miligramos por día dividido en 2 tomas. Cabe mencionar incluso que dentro de los paraclínicos de control, hablando de la citometría hemática, el paciente ha mostrado mejoría con una hemoglobina de 8.7 gramos, el cual también presentaba el patrón de normocítico normocrómico y plaquetas de hasta 36,000. Tomando en cuenta estos paraclínicos que se fueron documentando en el paciente conforme pasaban las semanas y meses, podemos tener en esta diapositiva los paraclínicos de forma inicial, de forma intermedia y conforme estuvieron obteniendo nuevos paraclínicos. Entonces podemos ver la mejoría que este paciente ha presentado, así como la constante o los constantes niveles de hemoglobina y la persistencia de una mejoría de plaquetas, en el cual podemos documentar cómo la hemoglobina ha ido incrementando, así como los niveles de plaquetas. Cabe mencionar que incluso el paciente posterior a julio del 2020 completó los primeros 6 meses de tratamiento con el trombopac, posteriormente se fue suspendido y por presentar plaquetas más de 30,000 y sin evidencia de hemorragia, el paciente se catalogó como un respondedor parcial ante este fármaco. Entonces, podemos mencionar que ante la mejoría y los niveles adecuados y niveles séricos de ciclosporina, el paciente se mantuvo con dosis de hasta 400 miligramos por día. Así podemos tener dentro de los paraclínicos, dentro de los más recientes, sin mencionar la de este mes, la última también documentada en enero del 2022, en el cual se observa mayor mejoría en los niveles de hemoglobina con una dosis de ciclosporina de 400 miligramos por día, en el cual ya se mantiene con una hemoglobina de 10.2 gramos sobre decilitro y un conteo plaquetario que se ha mantenido mayor a 30,000. Y podemos documentar mediante este cuadro los niveles séricos que el paciente se mantuvo de ciclosporina, así como la dosis catalogada en ese momento, en el cual, si podemos observar, hasta julio del 2020, fue cuando el paciente mostró la toxicidad por ciclosporina y se realizó desde ese momento la dosis reducción, esto tomando en cuenta los niveles séricos del fármaco. Hasta el momento, el paciente se ha encontrado estable, sin requerimientos transfusionales. Por tanto, podemos mencionar que la inmunosupresión más los trombomiméticos es una adecuada opción en pacientes no elegibles para trasplante que no pueden acceder o tolerar globulina antitimocito. Los efectos adversos que pueden observarse en estos pacientes pueden ser bien controlados. También cabe mencionar que nuestro paciente Una vez disminuida la dosis de ciclosporina A, mostró mejoría en cuanto a la clínica después de la toxicidad. Y por tanto, el tratamiento establecido en este paciente se ha mantenido como una terapia puente con intención a trasplante de médula ósea.
To be here in this another invitation from this lovely society, which I have had the opportunity to talk a few times. It's always been a pleasure. I was there a few times in Mexico, but I'm glad that we have the opportunity to engage and interact with this very important topic with a lot of new data. And more happily, I'm happy to be here since I was discharged a few days from the hospital 5-6 days ago after spending 2 weeks as an inpatient, a couple of days in the ICU. Not a good thing. So this is my first talk. So I'm hoping I can deliver the principal messages. My secretary asked if I would keep this event. I said, yes, I'll be strong enough. And I have been, and I've been recovering very well. So in the next 10-15 minutes, I'm just going to discuss a little bit about immunosuppressive therapy in aplastic anemia, and Dr. DeZern will obviously complement my talk with the advances in the transplant era. It's important to note that both modalities have actually changed the natural history of this disease. Transplants came a little bit earlier in the 1970s, immunosuppressive therapy in the late 1970s, early 1980s. And they really both saved lives and have been so since both of these modalities have actually were introduced and improved over time. So next, please. Here are my disclosures. Next. So this is an empty bone marrow. We will be talking about immune-mediated aplastic anemia. We're not going to be talking about Fanconi or dyskeratosis congenita or any of the forms that lead to a hypocellular marrow. There will be a talk on Fanconi later on. Next. This contrasts to a healthy-looking bone marrow from the same patient 6 months after immunosuppression. So the first message here is that marrow function can recover, and hematopoiesis can recover with IST or immunosuppressive therapy in patients with severe aplastic anemia with increase in counts, cessation of transfusions, and ultimately increase in cellularity. Next. We will be addressing immunoplastic anemia, and I think Dr. DeZern will be addressing the same group of marrow failure disorders, which are obviously immune-mediated with a lot of aberrant cytotoxic CD8 T cells, dysregulation with regulatory T cells that are decreased, interferon gamma, other cytokines, pro-inflammatory proteins that ultimately leads to destruction of hematopoietic stem cells, which undergoes apoptosis, hypocellularity, pancytopenia, and if not treated, death. So you can press the forward. This is, next please. This is an empty bone marrow, which leads to marrow failure, secondary to the destruction. And this is the pancytopenia, which are always very familiar by convention, less than 30% cellularity, without counting plasma cell and lymphocytes, associated with 203 pancytopenia shown here on the bottom. Diagnosis aplastic anemia, remembering everybody that this is a diagnosis of exclusion. So you do have to exclude, as was presented in the first case, some other abnormalities that can lead to a hypocellular marrow. Next. And pancytopenia. So the paradigm is, less than 40, if you have a matched family donor, you should go to transplant. If you're older than 40, IST. Now remember, there's never been a prospective randomized trial in frontline, which compared these two treatment modalities. The only transplant randomization frontline that defined transplant as a therapy was in the 70s by the group in Children's Hospital in Boston, a paper in the 1970s, 1975, 1976, where the Camilla criteria was born actually. If you have a very young patient, less than 18, and you can quickly find an unrelated donor that can be considered, but the logistics there plays a major role in being able to offer this in frontline. So most of the times patients end up going to IST due to lack of a matched sibling donor or comorbidities, age, or sometimes patient preference. Next. Immunosuppressive therapy was developed in the late 1970s and early 80s with ATG alone. Cyclosporin was added, and a lot of studies in Europe, the United States, and Asia have actually explored horse ATG cyclosporin and infant line. And you can see that a 60 to 70% younger patients, actually up to 80%, can actually respond, which correlates with survival. So if you can push next. So survival is dependent on response to IST. So IST so response is a very potent surrogate for survival in this disease. So if you respond to immunosuppression therapy, you're very likely to be alive long-term. It's not 100%, but it's very, very likely that you'll be alive. And there's some long-term follow-up curves to show that. Next. This is one of them. You can see here that among responders to IST at 3 months, you can see that survival going out 6, 7, 8, 10 years is actually very favorable. So very powerful and potent surrogate in this disease responding, showing that you have an immunomodulatory disease that can respond to these agents or a combination of these agents. The response is important. The lack of response is almost dire. The red curve, which is not as bad as today because there's been a lot of improvement with salvaging patients. And I'll show that in a few slides down the road. But this was dismal in the 1980s. You know, this is like a 20% survival in 5 years. This is like having metastatic hepatic cancer, which is the curve in red is really bad. But fortunately, that's not the case today. So response is important. Next. Age is also important. There is a very strong correlation between age and response to IST, and we've been looking for predictors for a long time. As you can see, children do better, 75%. Adults of all ages around 60%. If you're older than 60, your response rate approximates 50%. So age is a very potent predictor of response to IST, and children who respond to IST do very, very well. Next. This is a curve we published a few years ago, overall on the left, but you can see that among those who responded to IST, 90% survived really long-term. And this includes every patient. Those who relapsed, clonally evolved, obviously there's some patients here that were salvaged with transplants or second rounds of immunosuppression. But overall, including all patients, if you respond to your first round of immunosuppression, your survival long-term is really good. So it's a very favorable outcome if you do, children, if you do respond. Adults as well, but children is very, very remarkable. Next. Now, there's been several studies looking at predictors for response. Reticulocyte count is one of them. Lymphocyte count is another one. Several other cytokines that have been looked at, which are hard to test systematically, routinely on a day-to-day basis. PNH clone have been in some reports shown to correlate with the response. That has not been true in all reports, but most of them have actually shown some benefit of having a PNH clone and response to IST, especially reticulocyte counts. And obviously the horse formulation have been shown to be superior. Next. This is a more recent report showing that predicts a response with ACE, which is ATG cyclosporin Trauma-Pack, versus AC, which is ATG cyclosporin. And you can see that Retex correlates very well to response to IST. So does ANC. And ALC actually correlates with the response, but also correlates with complete response with ACE regimen. Not with ACE, but with ACE regimen. And a lower TPO level, which is interesting, correlates with the response to IST with ACE. So not having such a high TPO level actually is beneficial. So this is just a recent report looking at really 176 patients treated with ACE and a couple hundred treated with ATG cyclosporin alone. And here are some of the predictors that have actually correlated with response. Next. So, you know, although the algorithm still includes age and solely age and the presence of a donor, one can envision, and I'm not going to have time to show all the data that justifies what I'm going to say now, But if you have a guy who's 41 years of age with a severe aplastic anemia, negative Fanconi, telomere length, which is not short, obviously, telomere lengths have correlated with relapse and clonal evolution. If you have a long telomere, or in the it's unlikely that you have one of these late complications. If you have a high ARC, the positive PNH clone, you have a mutation in the PKG, no other myeloid mutations, all negative, this patient has a very high likelihood of responding to IST. This is not incorporated in algorithms. I'm being a little bit provocative, but we have quite a bit of data now to support that combination of these factors might actually predict even a higher group of patients who benefit from IST. Next, please. Now, not surprisingly, age correlates with survival in transplants. This is data from the EBMT up to 2010, published in 2017 by Andrea Bacigalupo. And very similarly, the younger you are, the better you do with transplantation. This is bone marrow transplantation. And these are cut in 3 groups, 0 to 20, 21 to 40, and over 40. And there is a problem in patients over 40. We still have a problem there. Even in the modern era. Next. Next. And this is true for one more. Oh, this is the EBMT data. Now go one more. This is, again, this is unrelated now. Unrelated, the same story. The younger you are, the better you do. The older you are, the worse outcomes you have. And you're talking about a 50% mortality here in a couple of years, 2-3 years. So it's a pretty high mortality over time in older patients. Next. And if you include TRM, bad graft versus host disease, they put in chronic. Obviously, not all graft versus disease is bad. You can treat most of them, but some of them can become very refractory to therapy, first and second line therapies. So about 5, 10, 20% of patients actually will have a really hard time if you include TRM, reactivations, infections, and the bad forms, grade 3, 4 is refractory of acute graft versus host disease. Next. And this is CIBMTR data basically showing the same thing. Age correlates with survival. Next. Now, Andrea Bacigalupo look at more modern. Remember, all the data I showed you from DBMT, CIBMTR went to 2010. Andrea Bacigalupo went to 2010 onwards and look at the older the age of 40, and basically there's no difference. You're really stuck at a 50% mortality with bone marrow transplant, match-related, matched-unrelated over a couple of years. So still really need help here in this arena. Next. The interesting thing is that the patients that benefit the most with ACE are the older patients, much more than the children, which is interesting. Children don't benefit as much, if at all, but older patients over the age of 20, especially with the age of 40, they do much better with ACE. Several efforts have been developed to improve on ATG cyclosporine, including a third immunosuppressant, rapamycin, mycophenolate, keeping cyclosporine for longer, granulocyte factors, rabbit ATG, cyclophosamide. Nothing really seems to consistently and systematically shown to be superior to, whereas ATG cyclosporine alone, showing that you don't need a lot of immunosuppression this disease, which is kind of interesting. You can just click twice. The next, I'm just going to show you. Next, please. Next, next, and next. Next. Now remember, one more. Remember that rabbit ATG and alemtuzumab are very immunosuppressive. They are lymphocytotoxic, like they drop your lymphocyte to 0 and it stays there for a long time. This is just a lot of studies comparing horse and rabbit ATG, horse superior to rabbit, and 2 meta-analyses actually showing the same thing, and all prospective trials showing the same thing. So if you can click next twice, there you go. These are the prospective trials, and this is the meta-analysis. So really not much question there. There might be some subgroups based on ethnicity that might respond to rabbit ATG better than this, but overall, this has been reproduced over and over, and large meta-analysis, including almost 1,700 patients. Next. So the idea here is to think different. Next. And to incorporate a drug that would, more immunosuppression didn't seem to, more immunosuppression didn't seem to do much better. So adding a drug that would stimulate stem cells, easier said than done. A lot of trials have been done to actually try to improve this outcome of increasing stem cells. We can't quantify this as much in the lab or in the clinic, but theoretically, it's something that could be possible. And stem cell factor and other interleukins have been tried in high-dose GCSF people. Nothing have actually worked. But since more immunosuppression didn't seem to be actually giving you better results, the idea then was to try to go back to the drawing board and increase your stem cell number. How do you do that is a different story. Next. Now, the TPOs were the ones that were approved in 2008 for ITP, which is a different disease, which we're all familiar with. And we decided to try to use this in Anemiaplastic anemia, not because it was going to work, but we thought it was not going to work, to be honest. But for a surprise, it actually worked well as single agent in second line and in front line in combination with IST. So I'm just going to summarize this data quickly in the next 5 to 6 minutes so you know where the data derives from that led to these approvals. Next. So TPO is expressed in a very early progenitor cell. You can see the cell in the top on the right. And it's been shown to, TPO is short for thrombopoietin. And it's been shown to be very important to maintain and modulate stem cells, both in vitro and in vivo, and obviously expands hematopoietic stem cells in vitro. So there's been a lot of support to actually test this in humans. And obviously humans that are deficient or don't signal through the MIPL receptor due to loss of function mutation, they do become pancytopenic over time. They become thrombocytopenic, megakaryocytopenic, and long enough, if they live long enough, they become pancytopenic, showing that thrombopoietin is important, not only in animal models, but also in humans. Next. The problem was with a very high TPO level, endogenous. And this really discouraged us and others to actually pursue this as a strategy, which was the reason that high doses were given, up to 150 milligrams in the pilot studies, and not the ITP doses of 50 or 75 milligrams. Next. So next, keep clicking. So here is about 40 patients that were treated. This is not the pilot 40 patients. This is the subsequent 40 cohort of patients. Next. Were treated with 150 milligrams fixed. Initially, the doses were ramped up to reach 150 every 2 weeks, starting at 50, 75, 100, 125. But at 150, the responses were seen. And starting at 160, giving it for 6 months, different from the pilot studies that started at 50, ramped up and gave it for 16 weeks. This was starting at 150 in day 1 and giving for 6 months. And this appears to be the most ideal way of giving this drug in second line in the patients who failed initial IST. 50% response, and most of them were robust, which is interesting because we know that patients who have robust response to eltrombopag actually are more likely to discontinue. Of the 20 responders on the left out of 40, 50%, 19 were robust and 15 were able to discontinue eltrombopag, which is kind of interesting. A cytogenic abnormality is something we've been following very, very, very carefully. And it can lead to mortality. That's why I'm going to focus a little bit on it. Next. Obviously, these responses in second line were associated with an increase in cellularity, as you can see here, pre and post treatment in some of the responding patients. Next. So, eltrombopag is probably increasing stem cell numbers, maintenance, even in the presence of interferon gamma. It's chelating iron, and it also has some immunomodulatory effects, which have been shown more in ITP, they're probably playing a role in Anemiaplastic anemia. So in the aggregate, you would probably have a lot of favorable effects of this agent in this disease. Next. So you're increasing stem cell numbers, and in combination with IST, one would argue and hypothesize that you would have the best regimen. Next. And this was a study, though. So this is all the eltrombopag trials that I summarized in a British Journal paper, all of them. Which use mostly EPAG. And if you average all this out, it's 50%. So 50% seems like a real number, which led to the trials in frontline. Initially, the NIH trial by Daniel Townsley, and then by the European, which compared a prospective randomized trial comparing AC to ACE. So I'm going to show you briefly the data of these two trials. Next. This was the American NIH trial, which started in 2000, and it was written in 2011, started in 2012. Again, 150 starting on day 14. We were concerned about hepatotoxicity at the time, so we gave a 2-week break. Later on, that was dropped to day 1, starting at 150 and giving it for 6 months. And cohort 3 was the best cohort, 30, about 92 patients in total, about 30 patients in each cohort. And if you go to the next slide, you can see here that the overall response rate was close to 95%. If you go to the next slide, whoever's on the slides. One more. Close to 95%, and complete response rate of about 50%. Now, this was a single-arm, non-randomized trial. So this was compared to a very rigorous historical control of all patients who were actually treated on a protocol with the same definition of disease, same definition of response, same everything. In the complete response rate of 10%. So when we look at 40, 50%, that seems to be favorable. The primary endpoint of this trial was with a complete response rate at 30%, which I'm really glad we chose that as a primary endpoint, because that's where the addition of ultra-compact ATG cyclosporin seems to do most benefit. Next. This is the 18-month follow-up published in 2017. Survival, as I mentioned, was, correlated with response. So you had a lot of patients responding, very few non-responders. And the survival, if you censor not for HSCT, was actually excellent at the time of publication. Next. Cytogenic abnormalities were seen, but some of them were considered high risk, which involved chromosome 7, dysplasia, lack of response, increase in blast, and sometimes leukemia. See if we can click next 3 times. No dysplasia sometimes seen, associated with some mutations, but there were cytogenic abnormalities of really unclear significance. Non-chromosome 7, no dysplasia. You can see the no dysplasia column. Great count, CR, 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 PR, CR, PR, PR. And sometimes these cytogenic abnormalities went away. So for the purpose of these protocols, any abnormality in cytogenics was considered evolution. So, but the ones that we really worry about are the high-risk evolution. Next. One more time. Keep going. So high-risk chromosome 7 complex myeloid malignancies, or high-risk MDS, and low-risk are all the other ones. Next. And when you look at really, this is long-term follow-up from 2021. If you count for every cytogenic abnormality, high and low risk is 14%. But when you look at high risk, you're really talking about 6% based on a median follow-up of about 3 to 4 years now. So less than half are high risk. And these are the ones that worry, and these are the ones that you actually have to consider transplant. So one of the arguments is that instead of giving transplant to everybody, you should probably think of those that are unlikely to respond to IST, or those who have a complication long-term, like high-risk clonal evolution, and really offer these modalities for these patients who are not going to do well with immunosuppression. Long-term follow-up, again, 3-4 years is over 90%. So still holding relatively well. Next, and if you're a partial or complete responder, your survival is probably even higher. Next, 95% or so. And this is after a median follow-up of 3 to 4 weeks. And this is including everybody, relapse, clonal evolution. Look at the non-responders, close to 78% or close to 80%. So even the non-responders are doing very well survival-wise, because they can be salvaged by many means, and transplantation is an important modality. Next. So L-Trauma was incorporated with IST and algorithms. It's now standard of care in adults, especially. In children, still less unclear. There's some dedicated trials going on children to see if the additional trauma pack. Children already do better. They already have a 75-80% response rate, about 30% complete. So it might be harder to show a difference in that patient population. But in the adults, there's no question that you clearly see a difference of adding ultra-pack to ATG cyclosporin, more so than you see in kids. Next. And this is another algorithm published, which I include the high risk and low evolution, and some strategies if patients don't respond to ACE in frontline, which is all published in the British Journal. I'm not going to go through this for the interest of time. Next. And to finalize my next 3-4 slides, the results of the RACE trial, which was a randomized prospective trial, 5-year trial, 200 patients, AC, ATG cyclosporin versus ACE in treatment-naive patients. Next. So basically, hematologic response complete at 3 months was the primary endpoint, and a lot of secondary known endpoints. They started at eltrombopag on day 14 because at the time the NIH trial was on the second cohort, which was a bit of a shame. We tried to change that at the time, but the protocol had already been approved by Novartis and by Pfizer, so we couldn't actually change. It was going to be too much of a hassle. So the protocol went on day 14, but one wonders if the results could have been better if you started eltrombopag on day 1. Next. So here's the data from the European EBMT trial. Arm B is ACE, three drug regimen. Arm A is 2 drug regimen, the standard. And you can see that the complete partial overall response rate was higher with the addition of eltrombopag to ATG and cyclosporin. So this confirms basically a lot of what was observed in the American trial. Next. Time to transfusion independence was to response was quick with with ACE, much quicker than with ATG cyclosporin alone, both first response and complete response and transfusion independence. Next. So we believe this is practice changing. Survival with IST, especially with additional eltrombopag, even with long-term follow-up, is close to 90% if you can include all comers, all patients, not only responders. So we think this is a really good option for patients at frontline. And as it was presented in the case earlier, before I finalized, there was a possibility of a transplant in that young patient that was presented just before I gave my presentation. And given all logistical and all whatever kind of issues, and I think there was an HLA matched sibling donor, so the patient should have got a transplant according to the algorithm. But starting on immunosuppression is so much quicker, so much easier, and you can do that anytime. So there's a logistical component here that allows to immunosuppression probably be the most applied therapy in severe aplastic anemia worldwide, given the fact that it's you can give it much quicker. And not every place has the logistics or all the logistics associated with undergoing a transplantation of the bone marrow, especially in a very rare disease. Next. So we obviously had the chance to write the editorial for this paper, and we believe that this is a practice changing. So the ATG was standard until 1991. Cyclosporin was added to ATG in a prospective randomized trial in 1991, was published by Freekhofen in the New England Journal. And 30 years later, and exactly 20 years later, in 2021, a new regimen arrives as first-line non-transplant for those not eligible for transplant, a standard immunosuppressive regimen in frontline in severe aplastic anemia. Next. And the SOAR trial, which is what you gave actually in the case presentation, which is eltrombopag with a cyclosporin without ATG, has been presented at EHA and at ASH, and we're currently writing the manuscript. In patients who are younger have a 55% response rate, and even those who don't respond actually do very, very well. They go on with transfusion independence. There's a lot of benefits that we will be including in the manuscript. So this is an oral outpatient regimen, which is much easier to give. I'm not going to show the data in the interest of time, but the data is available in the abstracts, and hopefully we'll be submitting this paper in the second semester. Next. This is the design of the trial. I'm not going to go into much detail. Next. And combining eltrombopag to cyclosporin is nice because eltrombopag has hepatotoxicity in 10 to 15% of patients. Cyclosporin renal toxicity, so they don't have overlapping toxicity. So they go very well together, and they act in different pathways. One is stimulating the bone marrow, the other immunosuppression. And keep in mind that in East Asian patients, the dose of eltrombopag has to be cut in half. Next. All right, this is my talk. Just next, I think I ran 5 minutes over just by saying next. But anyways, I'm glad to be here, healthy. This is our group in São Paulo, Brazil. This is my email for all of you who would like to actually reach out to discuss cases. I always learn, and it's always a pleasure to interact with physicians all over the world. It's a big learning experience, and the cases are great that are sent to us to opine. And I hope I am helping most of the times. Thank you very much.
Good evening, everyone. Thank you so much for the opportunity to talk to you about the transplant side of the potential debate here with Dr. Scheinberg for our young 22-year-old woman. So I'm Amy Dezern, speaking to you from Baltimore. I'm going to talk about what I think is a possible path to cure in this particular patient. I don't have any disclosures related to this. I do some consulting in the myelodysplastic syndrome world. And cyclophosamide, which we'll talk about, is off-label. So today I hope to review some very specific bone marrow transplant outcomes in severe aplastic anemia to speak in favor of consideration for an alternative donor transplant in this young woman with very severe aplastic anemia who did not have an HLA identical sibling. I'll talk to you about alternative donors in refractory disease, as well as the upfront use, which might be applicable to this patient, and you'll let me know what you think at the end. So you've heard a lot from my previous two colleagues about our therapeutic arsenal, and I just have to break it down in my own head and sometimes for patients in terms of how we offer the therapies that are available. And Dr. Scheinberg did a nice job of going into some of the clonal evolution data with L-trombopeg, but we do have to think about clonal hematopoiesis and any baseline aberrant mutations that might be present in any of us. And when in acquired aplastic anemia, there's that T cell attack at the level of the CD34 progenitor, we have to think about how we can combat it in an individual patient. I'm going to focus mostly on bone marrow transplant. And the reason I have chosen this is I think it's a very specific regimen. It's usually advocated for in younger patients and certainly all children who have a fully matched sibling. And the reason that is higher up in the algorithm in those patients is because it is potentially curative. Immunosuppressive therapy, which is equally available and maybe faster, as Dr. Scheinberg just spoke about, we favor horse. It's usually reserved for older patients, and I think the case of the 41-year-old gentleman is something that's closer and closer to my personal situation. For children who don't have full siblings, like our 22-year-old patient, and others not eligible for BMT. And it's not a cure, and it might be because after immunosuppressive therapy, we do have that issue and that risk of aberrant clonal hematopoiesis that could persist. So this is a standard algorithm that you've heard several of us review now. And all of this is based on the assumption that somebody, like our 22-year-old, has severe disease. We've focused a lot on age, and I do believe that's a moving target in the field. Much of the data that's been reviewed so far is a bit historical, and I think things are moving and changing. Matched sibling, though, is not available to everyone, and I think this is increasingly a truth in the age of blended families and mixed ethnic backgrounds. So there's increasingly a role for alternative donors because that matched sibling is certainly not ubiquitous, and we do not want to jeopardize a patient's potential therapeutic options simply because of who is related to them. And so I'll focus much of my talk on specific outcomes in the haploidentical arena. The measuring stick for all of us in transplant is based on matched related donors, those matched full siblings that have been around for so many years. And this is a high-level summary table going over some of what you've already heard. But you can see that this is a modality studied for many decades now. And some of the limitations, even in match-related donor transplant, have been acute and chronic GVHD. And Dr. Scheinberg showed you a nice slide of some of the limitations by age with these complications. But I think we've gotten a lot better since the late 1980s and even the early 2000s. However, that is the match donor transplant that's considered a cure, that is a standard which we continue to need to compare to because we want to do better than that. And I like this retrospective report from the Center for Bone Marrow Transplant Research in a slightly contemporary era from 2008 to 2013, because it was incredibly multi-center. And the point of this particular analysis was actually to look at horse or rabbit ATG as part of the conditioning for transplant. But ultimately, what I think is important to realize is that these patients of a span of ages who had matched donors, both related siblings and also unrelated, had engraftment in less than 3 weeks and chronic GVHD of 9 to 20%. It was noted to be less than with rabbit ATG compared to horse. And the overall survival at 3 years was somewhere between 92 and 87%. This is quite similar to the numbers you saw for survival for immunosuppressive therapy. And the late effects were pretty reasonable when the conditioning regimens for transplant were reduced intensity or non-myeloablative. And so any novel therapy, especially in the transplant arena, I believe must be better than this. These are the standard treatment schemas for a matched transplant. So even though the second gentleman that was presented as the case by Dr. Santiago had a matched sibling, and didn't go, this would have been the type of conditioning that could have been considered in that context. Some matched unrelated donors add fludarabine and TBI, and I'll show you that if we really optimize the transplant regimen, we can truly mitigate CVHD and improve upon outcomes overall. So when I talk to a patient like this young 22-year-old woman, we really talk about what would be ideal. And obviously it would be ideal if these patients never got severe aplastic anemia. But once we're there, we have to think about a therapy that's available to everyone and not limited by how old they are or who is related to them. Certainly low toxicity is important. And in somebody who meets criteria for very severe disease, as both of these cases have illustrated, neutrophil counts around 200 or 100 really are quite dire, and we must rapidly reconstitute the marrow to bring those counts up. And waiting sometimes 3 or 6 months is very uncomfortable. We need to do better. Certainly a low risk of treatment-related complications, and the most feared in the transplant arena is certainly chronic GVHD, which could just be replacing one complication for another, and also infection like CMV, and I'll show you some data in that regard. But the reason aplastic anemia is increasingly thought of as a transplant curable disease is because this does not carry the risk of clonal evolution that immunosuppressive therapy does. 6% is low, but it's not nothing. And I think in the MDS world, which is the other disease that I treat, we're increasingly learning about clonal cytopenias and the aberrant effects it has on other organs. And so if we can eliminate this, there's probably merit in that. And the way that this has come to pass could be a long talk about the history of cyclophosamide. A lot of this work has actually been done in Baltimore, but it's also been really adopted throughout the world. Cyclophosamide after transplant to prevent graft versus host disease was naturally first studied in mice, and it was used as standard prophylaxis at very low doses through the 70s and mid-80s. Then my colleagues, Leo Luznik and Ephraim Fuchs, realized that high-dose cyclophosamide after transplant at a human equivalent dose of 50 milligrams per kilogram could mitigate graft versus host disease in mismatched transplant. And really the whole point of this is this allows the use of haploidentical donors. So getting back to that ideal therapy, no longer must we have a matched sibling, as virtually everyone has 4.5 haplodonors, parents, children, obviously siblings, and even cousins. And this is ideal for something like aplastic anemia because you are replacing the blood-making organ, and that thereby cures the disease. And if all the other toxicity like GVHD can be significantly reduced, then it's worth trying. So this is currently called through the literature, the Baltimore regimen for severe aplastic anemia bone marrow transplant. And it's 3 doses of rabbit ATG, we don't use horse, cyclophosamide low dose pre-transplant, fludarabine, total body irradiation. We now use 400 centigrade for all patients in a single fraction on day -1. We always use a bone marrow graft, not peripheral blood, again, to mitigate against graft versus host disease. And then we use intensive GVHD prophylaxis with 2 doses of post-transplant cyclophosamide, as well as mycophenolate from day 5 to plus 35, and then tacrolimus to day 180. So this isn't someone who's going to necessarily need to be on immunosuppressive therapy with cyclosporin for 1 year or 2 years. We stop cold turkey at day 180. So this has been studied in several prospective experiences, and I would share this with a patient like our young 22-year-old so that they could really understand what the risks and benefits were and who the patients were. The initial trial was for relapsed and refractory and started about 8 years ago. The multi-center bone marrow transplant clinical trials network 1502 has completed accrual and has been submitted for publication, and I hope I'll be able to share that with you in the very near term. We then began using it for upfront treatment-naive patients, those who had not received anything other than transfusions for their diagnosis of aplastic anemia. There's a multi-center CTN trial forthcoming for this flavor as well in the untreated setting. We now use this as our complete standard, and I'll show you many more patients than were treated in the early trials and our standard of care patients. So this is a fairly recent analysis. We've done more beyond this, but we've done nearly 40 relapsed and refractory patients and nearly 30 treatment-naive patients as of this analysis a few months ago. As you can see, it's a range in both groups of pediatric and adult patients, about half male, also half very severe disease. These are patients with neutrophil counts less than 200. The majority of them have clonality at the time of presentation. And this is most often a PNH clone, but there are other occasional point mutations. I believe your young gentleman had an ASXL1. We see this as well. And something that's important, getting back to the ideal therapy, is we have a very blended population, especially in Baltimore, and a third in each cohort identified as a minority. So these would be people who are very unlikely to have an unrelated donor available. The donors come from a wide range of relationships to the patients, which is very gratifying when a cousin or an aunt, or certainly a sibling or a parent or a child, can step up and help their loved ones. We also have successfully used it for as much of a mismatch of an unrelated donor as a 7 out of 10, as there still are people who may not have anyone related to them for some reason or another. Getting back to the reasons to argue for this in somebody with very low counts is the rapid hematopoietic recovery. It is highly predictable and very gratifying to bring the neutrophils back over 1,000 in less than 3 weeks. The median is not different between relapsed and refractory disease and treatment-naive patients. You can see it's about 17 days, and the red cell and platelet engraftment follow very quickly thereafter. And currently, at least in the US, we're suffering with significant Red Cross blood shortages. And so this is incredibly important in that arena as well. So certainly we talked about an ideal therapy needing to have low toxicity. And in the relapsed and refractory setting, we continue to have low toxicity, though we have had deaths. This is a transplant and this is a real disease. Both were patients who were engrafted. The first one actually died from complications of renal replacement therapy. He was on dialysis and had an infection and actually was fully engrafted, but chose to avoid future dialysis in a palliative path. The second patient was also engrafted and more than 2 years after transplant, and in a separate setting developed probably a non-transplant related cancer. In terms of graft failure, certainly that is equivalent in aplastic anemia to a relapse or something not working at all. In that setting, there was one primary graft failure, but that individual was able to be salvaged using the other parent at day 50, and he's doing well. In the treatment-naive setting, there was a learning curve. We started this protocol at 200 centigrade in the treatment-naive patients, and unfortunately, there were 2 deaths from infection in patients who lost their graft after a primary and a secondary graft failure with the use of only 200 centigrade. The second of the 2 secondary graft failure was able to rapidly proceed to a second haploid transplant from a cousin. We had used the father the first time, and that person is alive and well. Based on this learning, and the adverse events we wanted to avoid, we augmented the total body radiation to 400 centigrade, and we have not had any graft failure, nor death, nor recalcitrant infections in the treatment-naive cohort since we augmented to 400. We now use it as our standard in the relapsed and refractory setting as well. We talked further about the necessity of low toxicity. And in the transplant world, this is almost always referring to graft versus host disease. It's not zero, but it's really very, very manageable. The rates of acute GVHD, that's grades 2 through 4, are 7% at 100 days. You can see the rates in the curves. These are cumulative incidents. And chronic GVHD at 2 years is also 7%. None of these have been extensive by the NIH 2014 grading scale. And the vast majority of patients are still able to come off immunosuppressive therapy by 18 months, and only one person was on it at 2 years. So getting back to overall survival and what I told you were our metrics to begin with, we wanted to be certainly as good as immunosuppressive therapy and contemporary matched sibling transplants. Currently, we are at 95% 2-year overall survival for all the SAA patients I've shown you to date. If we look at those at 400 centigrade alone, this is at 100% at the present time. And it's because 400 centigrade of total body radiation on day -1 in a single fraction is superior to 200 or regimens lacking TBI. It reduces graft failure as well as death. And this is the current data with the 38% of the patients I've shown you treated at 400. So what about infections? I get emails from all over the world about rates of CMV and EBV, and we in Baltimore have very low rates. That's one benefit of a haploidentical donor, that you can usually choose a favorable CMV pairing with your donor if you're choosing from 3 or 4 haplos available. We have had CMV viremia that necessitates treatment with valganciclovir, which is what we use in our hospital, or letermovir. We have not had anyone with end organ damage. In terms of EBV, this is something that the European colleagues have been very concerned about, but we have also not seen high rates of this. In the entire cohort that I've shown you, we've only had 4 patients, and in 3, it was simply documented viremia because we check weekly per standard, and only 1 patient received rituximab. The follow-up's becoming more mature all the time. This analysis was a few months ago. The relapsed and refractory data is out more than 5 years, and everybody's off immunosuppressive therapy. The treatment-naive cohort is equally growing and little past 3 years. And some of these patients have been transplanted more recently within the last 6 months and are still on GVHD prophylaxis. But we try and stop everybody without taper at day 180. So I'll just talk a little bit about healthcare burden, simply because this young woman was in her early 20s. And this is a particularly challenging age, at least for us in Maryland and in the USA, with how patients are often graduating from college sometimes, or coming off their parents' insurance. We have to factor these practicalities in whether we want to or not. I've mentioned the transfusion burden, and this is counting transfusions from the day the decision to transplant was made through their treatment period. And the burden attributable to the transplant is quite low and is not different for relapsed and refractory or treatment-naive patients. And I think this really is because there's very rapid hematopoietic recovery with the regimen that I've described, and so the burden of transfusions from the transplant is low. The other thing that's interesting to think about is certainly you saw very favorable data of the ACE regimen, but in the state of Maryland, how eltrombopag is reimbursed is quite complicated, and not everyone, especially younger patients, may not have great insurance. And it's really quite costly. And in our hospital, a transplant done with post-transplant cyclophosamide, which actually is an inexpensive drug, really is actually far less for a 1-year cost in our hospital. So hopefully today I've showed you that there is a path to cure with a post-transplant cyclophosamide bone marrow transplant for this indication, and that all patients can access it because we can use a wide variety of donors. This is a treatment approach that's useful in the relapsed setting, as well as in the treatment naive setting, like the patient case. I think there's excellent overall survival and hoping that someday it'll be at 100%, which is really what we'd like to see. The disease-free survival is equally important, as this is a disease that has a bimodal age distribution, and in young patients like our 22-year-old, she has many life years ahead to live, and I don't want her living with the fear of the clonal evolution coming some 10 or 15 years later after she's established in her career and has her family. Rapid hematopoietic reconstitution is part of the low toxicity, but I've shown you the rates of GVHD, acute and chronic, less than 10%, which is very good. And we've talked about cost. And as I alluded to, I'm looking forward to getting out the trial results for the multi-center, which is equally favorable. So this again is the Baltimore regimen for severe aplastic anemia. And so for our case, who would be a real person, I would ensure that she did not have an inherited bone marrow failure syndrome. This is important to rule out short telomere syndromes and Fanconi, which you'll hear about later in the night, as this post-transplant cyclophosamide probably is too much alkylating agent for these two disease types. I would talk to her about her personal goals, because I believe both modalities that you've heard about tonight are equally reasonable. We just have to understand what the goals are. We didn't talk a lot about fertility, but that's obviously one large difference. There is fertility preservation with this transplant regimen. I have patients who've become pregnant, but it is less of a guarantee, shall we say, as it would be with the ACE regimen. We talk about finances and timelines. We HLA type those near her who we can. And then I probably would offer her an upfront half loaf from the best available donor if she was hoping for a cure. So I'm grateful for your time tonight. I enjoyed hearing the other speakers' perspectives, and I'm certainly happy to take any questions. And I'm grateful to the whole team at home who helps make this regimen possible for our aplastic patients. Thank you so much.
Thank you very much. First, Gerardo, for the presentation of the clinical case. Some of the comments are congratulating you for the presentation of the case. And we also thank Dr. Martinez Murillo and Efren for helping you. We have many interesting questions. Both presentations were very interesting. I'll try to group the questions. Some questions are about the ideal treatment when we don't have access to ATG. So this is a reality for all of us. The access to ATG is not as simple as we wish, especially in the institutions where we lack coverage for patients. There's a question about this. It's about the initial doses of Thrombopac. I think Dr. Scheinberg could help us with this. Do you start with doses of 150 milligrams, or do you start with lower doses and then you increase the doses?
Always at 150, day one, in combination with at least cyclosporin. And the reason we designed the SOAR trial a few years ago is because in Latin America, when I came to Brazil from the United States, I realized that the ATG was an issue. It's not like the United States where you can get it easily in most places. So that's why we designed the trial with Eltrovac cyclosporin without ATG, or an ATG-free regimen, because it's oral, you can start, and we started at 150 and give it for 6 months. It's interesting that all the 3 frontline Eltrovac prospective trials are finite Eltrovac usage. So you give it for 3 or 6 months, 3 in the EBMT trial, if you had a complete response. If you're not, you went up to 6 months. And if you responded, you stop. And if you don't respond, you stop. So for the SOAR trial, which is Eltrovac cyclosporin, of 54 patients total, the Eltrovac was 150 on day 1, no ramp up, given for 6 months in combination with cyclosporin. That was the trial. I didn't show much of the data. It was only published in abstract form. But younger patients obviously do better. You can get a 55% response rate. And I think at the time of the analysis this is intention to treat, for the patients who actually completed the trial, the 6 months, the numbers are going to be a little bit higher. So it's an active regimen. It's an active regimen. And the difficulty I've had is that people have actually emailed me from all over saying that, is that okay to start while we plan for transplant? I said, yeah, transplant is going to be 3 months away. Might as well give something, instead of having a patient with, whatever, 50, 100 neutrophils for 3 months. The patient's it's not going to do well. And then they start on ultrampex cyclosporin, and at 3 months, when they're ready to transplant, the platelet is 80,000, the neutrophil count is 2,000, and the hemoglobin is 11. And they asked me, should we transplant the patient now? I said, I don't know. I don't think so. The counts look pretty good. They're not going to die of these counts the way they are. So the bridge approach is kind of tricky. But it's an active regimen. It doesn't work for everybody, but it can work for patients, especially younger patients. So it is an option in countries with more limited resources, like Mexico and several other countries I have visited around the world. You're giving active therapy. You're not giving anything, which is better than nothing, especially if you don't see coordination for a transplant, at least for 3 months. You might as well give something.
Okay, very interesting. And related to this for Dr. Amy, in the case of patients, the patient you presented that received this regime with cyclosporin and eltrombopag, and she had a good neutrophile response with a good partial response with platelets above 30 and 50. Do you think that this patient should be transplanted anyway, or any patient who responds with IST being young, when do they have to be transplanted later?
So I very much agree with what Phil just said. If someone no longer meets criteria for severe disease, then there is not an emergency to transplant. And there are patients who come wanting that with very good counts because they want the cure. And I have the honest conversation that the toxicity of the therapy is low. But at that point in time, with no infections, no transfusions, they're probably not having any toxicity from the aplastic anemia. So that is not the time to intervene. Certainly, it's a little bit of a different story if they've been on immunosuppressive oral regimen for a long time, and heaven forbid they're starting to evolve to something like MDS. Then we're less worried about some sort of depth of cytopenias to trigger the need for transplant. So I do reserve transplant in the relapsed and refractory setting and in the treatment naive setting for somebody who meets criteria for severe disease. ANC less than 500, platelets less than 20, transfused red cells.
Thank you very much. A question, I think Dr. Efrain Montaño can answer this. They are asking about the iron overload in these patients. They are talking about this, the case you presented. Do you know how many transfusions he received? And I could ask in general, what do you think about iron chelating agents in these patients? Hello? The patient was transfused before starting treatment. As Gerardo said, he was going to transplant, but then with the pandemic and everything, he started this protocol. We quantified it, and it was ferritin or iron was below before starting treatment. He didn't require a chelating agent, but we know that these patients, if they have an overload and go to transplant, is better. And if we have an adequate cytometry with this IST, we should tell them that, well, we should administer iron chelating agents.
Could we begin with Dr. Scheinberg? It is a question regarding a case. Is someone that has IST therapy with eltrombopag and cyclosporin. 100 milligrams of eltrombopag, platelet counts drops, and 150 milligrams of trombopag. So this patient presented more cytopenia. When would you decide to increase IST or decrease ATG or try to increase eltrombopag? Yes, when decreasing eltrombopag, blood count decrease. Well,
it actually, most patients regain their response. I have a patient just like that. When treated with ATG cyclosporin eltrombopag, we started decreasing or stopping her eltrombopag at 6 months, and gradually so I put her on a lower dose of eltrombopag. I didn't put her on the higher dose because she was off eltrombopag at that point, because we stopped eltrombopag at 6 months. And a few months later, her platelets are gradually started. So I put her on a low dose eltrombopag. I think it was 25 or 50. She was on a tapering regimen of cyclosporin. Cyclosporin is not stopped at 6 months. That's tapered, because then you can see a high rate of relapse. If you taper, the rate of relapse drops threefold. And she rapidly regained her response. So of the patients who actually in second line, even in front line, who you stop the eltrombopag, in the percentage of patients who actually see a drop in counts, you can actually go back on it or increase it a little bit, and they tend to regain the response almost always. Now, there is going to be the occasional patient that's going to just lose their entire response. Those you need to make sure that it don't clonal evolve, that's just a pure relapse. And in that case, if the patient's already on high dose cyclosporin and they're not responding to eltrombopag, you should be looking at transplantation as an option to salvage that patient. Because we don't know what second round of immunosuppression does with these patients, and they already got the 3 drugs frontline. Now, if they're on a lower dose of cyclosporin, you can actually go up on that. We had difficulty dealing with those patients at the beginning because we stopped both cyclosporin and eltrombopag in the first cohort, the first and a half cohort, about 30, 40 patients. And then they relapsed, some of them. And then we didn't know if we started cyclosporin first or started eltrombopag first or started the combination together. That was not embedded into the protocol. So we weren't sure exactly what to do. What we ended up doing actually intuitively was to start cyclosporin, give it 4 to 8 weeks. If they don't respond, then add eltrombopag. And many of them actually responded. But that's just not written in the protocol, and there's really no standard at that point. But of those patients who we actually stopped eltrombopag and they started seeing a decrease in the counts, almost always they regain their response when you put them back on it. You keep it, what I do, now this is not on a protocol, what I do is I keep them on eltrombopag for a little, 3, 4, up to 6 months and try to stop it again. And they can tolerate discontinuation then. It's not because they relapse, let's say, with the first time that they're gonna relapse again. You can try to re-challenge them again. And they, most of them tend to hold on to their counts the second or third time around. You should try to stop the drug as much as possible over time. Obviously, if you put them back on eltrombopag and you're a month out, that's too soon. You should wait at least a couple months to try to gradually. But in this case, I started her on a lower dose 50. I didn't go up to 150. And she already is in 200,000 platelets. So what we'll probably do, give her a few months and then try to do 25 and for 4 to 8 weeks, and if she tolerates, just stop it. And she'll probably tolerate at that point. We'll see. I'm not sure, but that's what we tend to see.
thank you. Thank you. And Dr. Martinez Murillo, if you could share some final comments, because we understand that the results look good trying to have first-line transplant of patients, but due to logistics in our country, it seems very complicated. So what do you what can you share regarding this whole scenario? Well, thank you very much. Just to conclude, to present the real world evolution at the Hospital General in Mexico, there are some restrictions on having an allogenic transplant program. So following the logic of treatment, we should leave in the long term the idea of a transplant. However, considering the case that was presented, we try to find a donor. Given the results published with El Trombopac, most of the patients lately have been treated with 170 milligrams of El Trombopac plus cyclosporine. So this year, the regime we use for SAA patients is 150 milligrams El Trombopac plus cyclosporine. Very few months we have applied this, and the tolerance has been good, and we are hoping, based on the results of previous trials as the one Dr. Montaño presented, that we will have good outcomes. For the benefit of these patients, and the idea is still in there, regardless of a good response, we always try to have, for those patients that are eligible, to have a transplant. For us, the waiting period is very young, but sometimes we see weeks go by, no months. But the idea with this, I would like to present a question to our speakers, Roberta, if I may, that the literature refers that we use 150, but the question, what if we increase it to 200? Will the response be quicker, better, or are we increasing toxicity? There are some reports that are already addressing this, but I would like to ask our guest speakers, how do you feel about modifying the dose, increasing it up to 200 milligrams?
Not because of toxicity. It was because at the time, nobody was giving such high doses, not even GSK. This was a GSK drug. It was developed by GSK that was swapped with Novartis at that $18 billion swap, and Eltrombopag went to Novartis. But this was the GSK time, and not even GSK had experience with higher doses of Eltrombopag. So it was stopped at 150 because I mean, not toxicity. And we started seeing responses at 125, 150, and we felt comfortable stopping at 150. Now, higher doses have been given. 225, 300. We have given 300 milligrams of Eltrombopag for moderate aplastic anemia, which has been published, and low-risk MDS. And patients do very well. I mean, you see very, very little in terms of increment of toxicity. So it looks like it's a drug that has a very large therapeutic window, which allows you to give, higher doses. Now, the question is, if you prospectively, systematically, on the protocol, gave 225 or 300 with ATG cyclosporine, would you get better results? We don't have the answer to that. Unfortunately, what we know is that starting early is better on day one with a cyclosporine and an ATG if you have available to ATG. But giving higher doses of 225, 300, which is tolerable, their skin just looks a little bit more bronzier. I mean, they look like they have a more of a bronzier discoloration, but that's minor. I mean, in terms of LFT abnormalities and some of the more important relevant things like thrombosis and reticulin deposition, we didn't see that, even at 300, and others haven't reported either. It seems to me that for marrow failure, and this is true for romiplastin and Eltrombopag, you need higher doses to reach that stem cell progenitor. If you look at the romiplastin data, it's 10, 20 micrograms per kilo, much higher than ITP. And if you look at Eltrombopag, you're looking at doses that are 300, even higher sometimes have been given. So it looks like for marrow failure syndromes, you need higher doses of these TPO agents in order to really hit that progenitor cell. For ITP, you have adequate stem cells, so 50, 75 seems adequate. But for marrow failure, if you look at both romiplastin and eltrombopag, and many trials in Israel, the MD Anderson, Europe, they use higher doses. Those higher doses seems to be the effective doses in marrow failure. And the number 50% keeps creeping up. In low risk MDS is 50%. In moderate aplastic anemia is 50%. And second line aplastic anemia is 50%. So if you're going to play Jeopardy or some game show, choose 50% for eltrombopag or any of these as single agent, because you're probably going to get it right. There's something magical about 50, but it's pretty consistent. 50%, 50%, 50%, both in MDS and in aplastic anemia. And in the real world as well, which is interesting, outside of clinical trials.
Okay, thank you. Thank you, everybody. Because of time constraints, we need to move on to the next presentation because Dr. Moises Fiesco, he's ready to present. Thank you very much. There were too many questions left unanswered, and I am certain that the speakers will answer it if you contact them by email. If you have a specific question, please do so. So thank you. Thank you to our three doctors from Hospital General and the three guest speakers, and excellent debate. And now it's time for the last part, which is about Fanconi anemia, which is really interesting. And you will see that Dr. Fiesco has a research line and a deep passion for Fanconi anemia.
Por la invitación. El día de hoy voy a hablar acerca de anemia de Fanconi. Yo soy médico especialista en genética y entonces el día de hoy no voy a profundizar en algo que ustedes ya conocen y en lo que son expertos, que son las características hematológicas de la anemia de Fanconi, sino voy a tomarme la oportunidad para hablarles acerca de dismorfología en anemia de Fanconi. La dismorfología pues es la parte de la genética que estudia las alteraciones en la forma y que nos permite además poder tener bajo nuestra propuesta un diagnóstico temprano de la anemia de Fanconi. Trabajo en el Instituto Nacional de Pediatría y vamos a empezar. Entonces, se estima que en el mundo 1 a 5 personas por millón padecen anemia de Fanconi. Esta enfermedad se ha estudiado más en población caucásica, entonces todos estos datos provienen de esta población. Puede saltar la pregunta de cuántos casos hay en América Latina, ¿no? Tenemos más de 640 millones de habitantes en esta región, entonces deberíamos tener entre 646 y 3.230 personas con anemia de Fanconi, y para México el número no es diferente, sino se asume que podríamos tener entre 126 personas y 630 personas viviendo con anemia de Fanconi en nuestro país. La anemia de Fanconi puede agrupar sus características, sus manifestaciones en tres. Son las alteraciones del desarrollo físico y nosotros evidenciamos a través de una revisión de la literatura que alrededor del 80% de los pacientes presenta al menos o se ha descrito una alteración del desarrollo físico. En el 96% de los pacientes se presentan alteraciones hematológicas y hasta en un 20% alteraciones oncológicas. Estos dos últimos a través de estudios prospectivos. Las alteraciones del desarrollo físico que se presentan en anemia de Fanconi fueron clásicamente descritas como parte del acrónimo Bacter, ¿no? Que es algo que en medicina conocemos bastante bien. Sin embargo, en 2016, las doctoras Alter y la doctora Giri crearon este acrónimo que es FENOS, alteraciones pigmentarias de la piel, cabeza pequeña, que es small head, small eyes, alteraciones neurológicas, es la N, la O es de alteraciones otológicas y la S es de short stature. Y definen alteraciones que son frecuentes en los pacientes con anemia de Fanconi y que no pertenecen al acrónimo Bacter. La expresividad es muy variable. Podemos tener pacientes que no presenten aparentemente ninguna alteración del desarrollo físico hasta pacientes que tengan más de 8, 9, 10 alteraciones del desarrollo físico. Con respecto a lo hematológico, pues este es uno de los síndromes de falla medular hereditario más común, más frecuente. Normalmente los pacientes tienen una mediana edad de presentación de 6.5 años y el dato inicial generalmente es la plaquetopenia. Después se presentan bicitopenias y finalmente una pancitopenia. Ahora, llamar su atención a estos hallazgos que nos pueden ayudar muchísimo en el abordaje de una falla medular, ¿no? Cuando encontramos parámetros como hemoglobina fetal, ancho de distribución eritrocitaria o el volumen corpuscular medio elevado, esto es consistente y compatible con una falla medular hereditaria. Con respecto al cáncer, los pacientes con anemia de Fanconi tienen 20 veces más riesgo de desarrollar cualquier tipo de cáncer. La mayor parte son leucemias, pero en la tabla ustedes pueden ver riesgos altísimos. Por ejemplo, 5,000 veces más riesgo para síndrome amiloidisplásico, 200 veces más riesgo para leucemia amiloide aguda, inclusive 500 veces más riesgo para tumores sólidos como las células de escamosas de cabeza y cuello. La anemia de Fanconi es una enfermedad genética. ¿Por qué? Porque obedece a cambios en el ADN, en alguno de los 22 genes que hasta el momento están asociados con el fenotipo, y es una enfermedad hereditaria, porque los pacientes presentan patrones de herencia como autosómico recesivo ligado al X, y hay un gen incluso que es autosómico dominante. ¿Qué tienen en común estos 22 genes de los cuales les hablo? Estos 22 genes, que se describen como de FANCA a FANCW, pertenecen a la vía FABRCA, que seguramente conocen porque es una vía alterada en la reparación del ADN y tiene que ver mucho con cáncer hereditario. Cuando se presenta un enlace covalente cruzado entre la hebra Watson y la hebra Crick del ADN, la vía de Fanconi se activa. Se activan primero las proteínas riba-arriba. Estas proteínas riba-arriba tienen como función principal ubiquitinizar al complejo ID, y el complejo ID activa los genes riba-abajo, finalmente llegando a la reparación del ADN libre de error a través de recombinación homóloga. Ahora bien, algunos de estos genes han presentado asociaciones genotipo-fenotipo, por ejemplo, FANCN y FANCD1, con tumores como leucemia amiloide aguda, cerebro, tumor de Wilms, el gen FANCD2 con la presencia de características de fenos, de las cuales les hablé, y el gen FANCB con características de Bacter. Estas dos últimas nosotros las evidenciamos a través de una revisión de la literatura, en la cual encontramos que el gen FANCB se encuentra fuertemente asociado con las características de Bacter y el gen FANCD2 con las características fenos. Ahora bien, no importa si los pacientes tienen alteraciones hematológicas solamente, alteraciones del desarrollo físico o presentan una mezcla de cualquiera de estos tres grupos. El diagnóstico se puede hacer a través de un estudio citogenético con el uso de agentes alquilantes bifuncionales que evidencia esta falla en la reparación del ADN a través de rupturas cromosómicas, rupturas cromatídicas y estas figuras de intercambio radial que son muy específicas de anemia de Fanconi. El Laboratorio de Citogenética del INP es el Centro de Referencia Nacional para el Diagnóstico de Anemia de Fanconi, lleva más de 30 años haciendo el diagnóstico en México. Pueden ustedes conocer este estudio como aberraciones cromosómicas, rupturas cromosómicas, fragilidad cromosómica o estudio de Ebv o de mitomicina. Y lo que se hace es que se toma la muestra problema de nuestro paciente, un control negativo, que es un individuo sano, y un control positivo, que es una línea celular de anemia de Fanconi. Se hacen cultivos a la par, con reto y sin reto, y después de 72 horas se hace una cosecha convencional, una tinción homogénea y se analizan estas alteraciones cromosómicas. Esto nos permite entonces tener una diferencia entre un individuo sano, que están en verde más oscuro y verde más claro, los pacientes con anemia de Fanconi. A nivel basal ya hay una diferencia. Sin embargo, el reto con Ebv y el reto con mitomicina permiten evidenciar más esta diferencia, y es lo que hace que este sea el diagnóstico, el estudio de referencia diagnóstica. En el laboratorio de citogenética del 99 al 2019 se analizaron 1,200 individuos, y de estos se encontró que el 12% eran positivos para anemia de Fanconi. Esta se hizo una división de 10 años, pero podemos ver que del 1999 al 2019 se han encontrado esta tasa de positividad del 12%, y el número de individuos ha aumentado con diagnóstico de anemia de Fanconi en los últimos años porque nos llegan más muestras. Sin embargo, algo que desconocemos totalmente es cuáles son las alteraciones que condicionaron la sospecha de estos pacientes. Sabemos que nos los mandan, pero no sabemos por qué nos los mandan. Se han identificado casos positivos en diversos estados de la República. Los estados iluminados son aquellos en los que se han identificado algunos casos en estos años. Sin embargo, estamos muy lejos, con 160 casos de los 630 que esperaríamos en México. Para esto, a través de un estudio que se registró en el Instituto Nacional de Pediatría, se creó el registro de anemia de Fanconi de México. Este es un estudio que tiene como base el Instituto Nacional de Pediatría y el Laboratorio de Citogenética con diferentes especialidades que de forma interdisciplinaria nos apoyan para tener apoyos también en otras instituciones, finalmente en el marco del envío de médicos referentes, el apoyo por fundaciones para el estudio y el apoyo de los pacientes con anemia de Fanconi, y tratando de cuadrar todo esto en el apoyo a las familias, creamos este estudio que nos permite ser el primer esfuerzo mexicano y en América Latina para la creación de un registro formal de pacientes con anemia de Fanconi. Es un estudio analítico, longitudinal, observacional, ambispectivo y ambilectivo que tiene como objetivo describir y analizar las características de los pacientes en los que se sospecha anemia de Fanconi, pero también en aquellos en los que se diagnostica anemia de Fanconi en nuestro país. Utilizamos una plataforma que es un servicio de telemedicina que es encriptado y seguro para transmitir información que nos permite recolectar de forma sistemática y ordenada datos de las 3 esferas de afectación de los pacientes. A través de este cuestionario nosotros recibimos información de todas las médicas y médicos referentes del país y entonces nos permiten recibir estos casos. Ahí les presento que hasta hace 2 meses se habían recibido 48 casos. De estos 48 casos, 6 resultaron positivos para anemia de Fanconi y 42 negativos, lo cual nos da una tasa de positividad exactamente igual a la que teníamos, 12.5%. Ahora les comentaba que nosotros no sabíamos cuáles eran las características de los pacientes que antes de que iniciara el registro se enviaban para el diagnóstico. Aquí les presento una tabla en la que estoy comparando todos los casos positivos y los negativos. Llamo su atención a la diferencia de edades. Los pacientes con diagnóstico positivo se están diagnosticando a una menor edad que los negativos. Esto es estadísticamente significativo. Y algo también interesante de esto es que ya conocemos por qué nos mandan los casos positivos. El 70% aproximadamente tienen alteraciones del desarrollo físico, más alteraciones hematológicas, y un 15% más o menos tiene alteraciones del desarrollo solo como sospecha o alteraciones hematológicas. Ahora bien, esta es una línea del tiempo en la cual se presentan como las sospechas de motivos de sospecha del diagnóstico de anemia de Fanconi, y vemos que la edad promedio del diagnóstico de anemia de Fanconi, según lo reportado en la literatura a nivel mundial, es de 7 años. Nosotros encontramos una edad diagnóstico de 5.5 años. ¿Por qué intentamos explicar esto? ¿De qué manera intentamos explicar esto? Ya que algunos de los referentes y las referentes son médicos que sospechan anemia de Fanconi antes de que empiecen las manifestaciones hematológicas por datos dismorfológicos, alteraciones del eje radial, alteraciones renales, talla baja, microcefalia, alteraciones pigmentarias de la piel. Y esto probablemente nos permite tener una edad de diagnóstico más temprana que la reportada en la literatura, al menos en este grupo de pacientes. Todos los pacientes que han sido diagnosticados con anemia de Fanconi en nuestro país, ya sea que entraron en el colegio telemédico con estos 48 casos o que han sido diagnosticados en otro centro o previamente, han sido invitados a participar en el RAFMIX. A través de entrevistas recabamos información que nos permite generar respuestas. Entonces les presento que iniciamos en junio del año pasado y a la fecha hemos reclutado 26 pacientes con anemia de Fanconi de diferentes estados de la República. Para una enfermedad tan poco frecuente es un número muy elevado de pacientes y aún tenemos unas entrevistas pendientes, algunos otros pacientes que prontamente estarán ingresando en el registro de anemia de Fanconi si así lo desean las familias. ¿Qué resultados tenemos hasta la fecha? Yo les había dicho que se ha reportado que hasta el 80% de los pacientes con anemia de Fanconi tienen al menos una alteración del desarrollo físico. Y esta es una gráfica que publicamos en 2019 con esta revisión de la literatura, y se ve que las alteraciones de Bacter más frecuentes son las renales y radiales, y de las de fenos son alteraciones pigmentarias, microcefalia y talla baja. Pero vean que ninguna llega al 50%. Todas se han reportado en menos del 50% de los pacientes. Estos son los datos de nuestros 26 pacientes. Tenemos que las alteraciones de Bacter más frecuentemente reportadas son las renales y las radiales, como lo previamente reportado en la literatura. Pero llama la atención que lo radial, que son las alteraciones de extremidades superiores del eje radial, superan el 60%. Y si nosotros volteamos a ver las alteraciones de fenos, estas se reportan, o más bien, estas las encontramos en los pacientes en el 100% de los casos. El 100%, o sea, los 26 pacientes del RAFMEX tienen alteraciones oftalmológicas y el 100% tienen alteraciones pigmentarias de la piel. Ahora, con respecto a las alteraciones del eje radial, hemos encontrado igual este espectro de anormalidades. Vean ustedes todas las manos que se encuentran del lado izquierdo de la pantalla. Si ustedes las observan detenidamente, parecen manos normales. No parece haber una alteración, al menos evidente a la inspección física, de alteración del eje radial. Vamos a la siguiente columna. En la siguiente columna empezamos a ver alteraciones a nivel de la eminencia tenar. Entonces, una hipoplasia tenar puede ser la manifestación más leve de alteración del eje radial. En la siguiente columna vemos pacientes con oligodactilia, donde es muy evidente que falta un dedo. Y en la última columna tenemos pacientes con polidactilia preaxial. Entonces podemos encontrar desde manifestaciones crípticas hasta manifestaciones muy, muy floridas en los pacientes mexicanos. Estos pacientes también comparten características a nivel facial. Una cara triangular, que es la clásicamente descrita como facies de anemia de Fanconi, alteraciones a nivel de los ojos como ptosis o fisuras palpebrales cortas, hiperpigmentación a nivel de los orificios faciales, y estos datos dermatológicos los hemos caracterizado con apoyo del equipo de dermatología pediátrica del Instituto Nacional de Pediatría. Lo que hemos encontrado es los hallazgos que nos permiten entender y redefinir estas alteraciones dermatológicas, como por ejemplo las alteraciones pigmentarias a nivel periorificial. Si ustedes observan detenidamente estas caras, llamaría su atención que alrededor de la boca, alrededor de las narinas y alrededor de los ojos parece haber una hiperpigmentación comparada con el resto de la cara. También hemos visto que además de las alteraciones de manchas café con leche, que son clásicas en anemia de Fanconi, vemos también alteraciones como manchas hipopigmentadas. Y finalmente hemos encontrado lesiones que no son esfélidos, sino más bien son neoformaciones de aspecto papular, lesiones que no han sido descritas en la literatura y que nos permitirían tener una sospecha de anemia Fanconi a una edad más temprana, incluso antes del inicio de las manifestaciones hematológicas. Como datos hematológicos de estos 26 pacientes, la mediana de edad de manifestaciones hematológicas fue de 5 años. 25 de los 26 ya tienen alteraciones hematológicas, siendo la más frecuente la trombocitopenia, seguida muy de cerca de anemia, y el 77% de los pacientes presentan alteración de los leucocitos. 5 de los pacientes han sido trasplantados, esto es un 20% del grupo. Y con respecto a los tumores, vemos que 2 de nuestros pacientes han desarrollado un tumor. Una paciente presentó un tumor a nivel de respirador oral, y otro paciente síndrome mielodisplásico. Ahora bien, cierro parte de la charla con estas 5 ideas claves para el diagnóstico de anemia de Fanconi que pueden detectarse desde la primera visita. Una historia familiar, antecedentes de cáncer, malformaciones, otros hermanos que hayan fallecido. La facies particular, que es una facies triangular con hiperpigmentación periorificial, ojos pequeños. También la talla baja, que es un dato que podemos detectar en la primera exploración física. Las alteraciones pigmentarias de la piel, entonces les invito a revisar a sus pacientes en todo el cuerpo para revisar estas alteraciones. Y finalmente las alteraciones del eje radial, que son bastante frecuentes en los pacientes con anemia de Fanconi, son clásicas del fenotipo. Este es un algoritmo diagnóstico en el cual nosotros partimos de estas alteraciones del desarrollo físico y aunado a herramientas como la evaluación por otros servicios, pues se puede solicitar el estudio de Ebv y de mitomicina C. Pueden contactarnos para hacerlo. Estamos recibiendo muestras de todo el país. Todos los médicos y médicas que sospechen anemia de Fanconi pueden contactarnos y podemos discutir el caso para recibirlo para el diagnóstico. Si es un diagnóstico positivo, pues se empieza todo el manejo de los pacientes, pero si es un estudio negativo de Ebv o de mitomicina y su índice, o sea, el nivel de sospecha es alto, podemos a lo mejor proponerles hacer el estudio en otro tejido que nos permita descartar mosaicos o algún otro tipo de manifestaciones y finalmente pues, llegar a un diagnóstico de la enfermedad. ¿Qué perspectivas tenemos? Y les quiero contar de lo que estamos haciendo ahora, es analizar estos casos positivos y negativos y proponer criterios diagnósticos para la anemia de Fanconi que no existen, y así como analizar las características dismorfológicas de los pacientes, porque creemos que a través del estudio de la anemia de Fanconi podemos nosotros entender cómo se llevan a cabo este tipo de alteraciones a nivel dismorfológico. Definir la facies de anemia de Fanconi, que es ambigua en la literatura, describir el espectro de malformaciones y de alteraciones funcionales en nuestros pacientes. Estamos llevando a cabo un estudio en el que pretendemos entender cuál es el espectro de anormalidades físicas en la anemia de Fanconi. Es una revisión de la literatura en la cual partimos de la previa de 2019, agregando todos los casos descritos hasta la fecha, y hemos llevado ahorita 659 casos de anemia de Fanconi con genotipo descrito, que eso nos permite disminuir la posibilidad de falsos positivos. De estos, igual el 80% tienen al menos una alteración del desarrollo. La mediana de malformaciones descritas es de 2, pero hay un rango de pacientes que no se describe ninguna a pacientes que tienen hasta 15 anomalías. La mayoría son anomalías mayores, es decir, afectan la vida o la función, y esto llama la atención porque entonces permite que a un paciente que tenga alteración renal y radial, microcefalia y alteraciones oftalmológicas se pueda sospechar de anemia de Fanconi. El 12% de los pacientes cumplen criterios para Bacter, que son 3 o más de las 8 anomalías de Bacter, y el 8% de los pacientes tienen 4 o más de las anomalías de Phenus, que es algo bastante frecuente en nuestra población. Y lo que hemos descrito es que hasta el momento, más de 190 anomalías en toda la economía se han descrito. Todos los aparatos y sistemas pueden estar tocados en anemia de Fanconi: piel, oído, cabeza, corazón, riñón, eje radial, etc. Este es un tree map en el que les permiten identificar cuáles son las anomalías con más número de alteraciones. Son las neurológicas, con 33 anomalías diferentes, y las faciales, con 20 anomalías diferentes. Tenemos como pendiente agregar otros casos, porque les quiero presentar que este año se publicó un grupo de 3 pacientes en los cuales, a través de estudios de genoma, se identificó una variante fundadora en el gen FANG. Estos son los 3 pacientes, son 3 pacientes que tienen diagnóstico de anemia de Fanconi a través de reto con DEB, que llegaron al Instituto Nacional de Pediatría provenientes de Oaxaca. Se analizó el índice, el porcentaje de componente nativo, y se vio que es alto. El coeficiente de consanguinidad también demostró que estas 3 personas estaban relacionadas, aunque ellos no se conocían como parientes. Hicimos un análisis comparando los 3 genes más frecuentemente afectados en la anemia de Fanconi. Hasta el 60 y tantos % de los pacientes tienen afectaciones en FANK, 10 a 15 en FANC, igual en FANG, y lo que notamos es que FANG es el gen que tiene más variantes fundadoras comparadas con los otros 2 genes más frecuentemente reportados. Y esta es una tabla en la que se presentan las características de nuestros pacientes: la edad del diagnóstico, las alteraciones hematológicas, el estatus de la falla medular, y que ambos, los 3 pacientes, tenían tanto criterios de Bacter como criterios de Phenus como parte de sus características clínicas. Entonces, ¿qué nos permite este estudio? Nos permite evidenciar una nueva variante patogénica fundadora en FANG, determinar que FANG es el gen con la proporción más alta de variantes patogénicas fundadoras, describir que el fenotipo de los pacientes Mije, porque venían de la Sierra Mije de Oaxaca, concuerda con lo descrito para otros pacientes que tienen afectado el gen FANG, y que la identificación de esta variante patogénica fundadora da un paso importantísimo en el estudio de la población mexicana, porque nos permite buscar portadores y tener un diagnóstico y un manejo temprano, por ejemplo, si llegara a haber más pacientes dentro de esta población específica. Muchas gracias a todos y a todos por su atención. De verdad, les agradezco la invitación. Agradezco a todas y a todos nuestros pacientes, pero especialmente a Iker, a Cooper, a Iván y a Marvin, que desafortunadamente han fallecido en este último año, pero que nos han permitido generar toda esta información que seguramente tendrá un impacto en un diagnóstico más oportuno de los pacientes con anemia de Fanconi, en un entendimiento más específico de las vías de la reparación en el ADN que condicionan alteraciones dismorfológicas, y en el estudio en general de la falla medular. Quiero agradecer a todas las personas que hacen posible este esfuerzo: a la doctora Sara Frías, a la doctora Benilde García, al doctor Alfredo Rodríguez, a la doctora Marimar Sáez y a la doctora Andrea Venegas, así como todo el equipo del Laboratorio de Citogenética, la maestra Berta Molina y Silvia Sánchez, que hacen posible el diagnóstico y seguimiento de los pacientes. Y quedo muy contento de haber sido invitado a esta charla. Les dejo mis datos de contacto, los datos de contacto de la doctora Benilde García, que es la encargada del registro de anemia de Fanconi de México, y estaremos dispuestos a discutir cualquier caso que ustedes tengan para el diagnóstico de anemia de Fanconi. Muchísimas gracias.
Muy bien, pues con esto terminamos esta sesión que ha sido, creo, muy productiva, muy interesante, con las presentaciones tanto del caso clínico como las del doctor Scheinberg y la doctora de CERN, y por supuesto la presentación del doctor Fiesco con el registro mexicano de anemia de Fanconi. Les recuerdo la fecha del congreso de este año de la Agrupación Mexicana para el Estudio de la Hematología, 26 al 29 de octubre en la ciudad de Guadalajara. Y muchas gracias a todos ustedes, gracias a Novartis por participar y apoyar esta actividad académica, y que tengan ustedes muy buenas noches. Hasta luego.